So we're going to carry on. So now
This meeting is being recorded.
Right, so we're going to carry on. We're on case 3 now. So it's day 2 of your night shifts, and 11 p.m. You have a 43-year-old male that comes in with an unwanted and painful erection that he developed when he awoke from his sleep. So the key thing in this referral is the fact that it was unwanted and the fact that it was a painful erection. So you get a referral from A&E and they've already tried and they've been unable to reduce his erection. And he's come in at the 6-hour mark. So it's already been 6 hours since he's had this erection. And then you say, bring the patient in immediately. And 4 hours later, the patient arrives. As you can imagine, there are always delays in our service and this patient comes in way too late. So he's arriving at 10 hours and we're already quite worried about him. So I'm just going to quickly tell you the differences between a flaccid and erect penis, because this is important in discussing priapism, which is what this gentleman has. So in a flaccid penis, you can see the cavernosal arteries versus the erect. So in the flaccid, the cavernosal arteries are more constricted. When it's erect, the cavernosal arteries are enlarged. You have more blood supply coming in, and the veins are closed off to try and keep the blood within the penis, within the cavernosum, to try and keep the penis erect. Okay, so this is the main pathophysiology that you need to be aware of. Now, in priapism, there are 2 main types of priapism, and one of the types is an emergency. And I have seen a patient that's come in with an unwanted erection. It's been 12 hours and they've come in and we've done everything that we can, and they've still had to end up with a penile implant, which basically means that they can no longer use their penis for any sexual activity. And that is the worst possible outcome that you can achieve. And this, well, I say worst possible outcome, they still have a penile implant, they can still have erections at the end of the day. But, if they had been seen and treated much earlier, they could have avoided all of that. They could have avoided that complication, which is why when somebody comes in with an unwanted and painful erection, it's really, really important to be, alerting all of your team members about it, because it's a very specialist scenario to happen. It is not so common in the UK, and only very specific surgeons are comfortable managing this, and most likely it will have to go to a tertiary center. Okay, so 2 main types of priapism. There is high flow or non-ischemic priapism versus low flow ischemic priapism. Now, we're more worried about the low flow ischemic priapism, as you can imagine, because of the term ischemic. So veno-occlusive means the venous drainage is blocked. As we discussed, in an erection, the venous drainage is complete, it's blocked, and the blood doesn't have anywhere else to go, and it's not circulating with any new oxygenated blood. So they have ischemia to their penis, becomes fibrosed, and eventually they develop impotence. The causes of this are really important to be aware of, and I'll just go through a few of them. So iatrogenic causes, so usually people taking certain drugs is more likely to cause it. And another big one to be aware of is sickle cell disease. If someone has a sickle cell crisis, they can have a priapism as well. Okay. Now, high flow non-ischemic is when the arterial blood is filling into the corpus cavernosum. The venous drainage is still there. It's still being drained. It's not veno-occlusive, but it's just that the arterial blood is flowing in more quickly than the venous outflow. So you still have a semi-erect penis, but it's more flaccid than normal, and it tends to be associated with trauma or any sort of sexual stimulation. In these patients, we're usually more worried that we have to investigate their penile perineal trauma or the spinal cord injury than to deal with the priapism immediately. This type of priapism is quite common in trauma patients that come in after road traffic accidents, and you tend to pick this up on a primary survey of a patient coming into A&E with trauma. This is one of the features in ATLS that they tell you to look for. So let's put high flow non-ischemic priapism to the side, and today we'll discuss low flow ischemic priapism. The causes that you need to be aware of, because some of your patients might be on these medications or might be overusing some of these medications. So cocaine, so being a drug user is quite a big risk factor. And actually one of my registrars / friends was saying that where she lives in Barcelona, they have patients coming in with priapism daily. Well, we have patients coming in with priapism, I would say once every 3 to 4 months. And I've seen a couple of cases having been on this particular placement for roughly 6 months. So it's not something that's common that we see, but obviously quite common in other parts of the world. So intracavernosal drug therapy, just a fancy word actually for Viagra. Lots of patients that overuse Viagra or use Viagra in any way tend to be more likely to be at a risk for priapism. Yeah. Alcohol, antidepressants, alpha blockers, heparin, these are just other medications to be aware of. So stuttering priapism, I thought I'd just put one slide on this, but nothing further. Sickle cell patients tend to get stuttering priapism, which is basically when you keep getting priapism like a stutter. So it's intermittent, it's repetitive, and it's very painful, and it lasts for tend to be a short amount of time compared to the ischemic priapism that we're just discussing. It tends to go away on its own. And the risk of having a priapism in patients with sickle cell is actually up to 40%. So quite common, I would say, and something to well be aware of, because it might even sometimes be their initial presentation. Okay, so if someone has priapism, how would we investigate them? So we would do bloods for them as normal, but this corporeal blood gas is really, really important in making the diagnosis and the distinguishing factor between a high flow and a low flow priapism. Okay, so how do we get corporeal blood gas? I'll show you a picture later, but basically we use a butterfly needle and we inject straight into the corporeum and take some blood from there. Patients don't enjoy this very much, but obviously for reasons that we both know that this is quite important to do. You run it just like you would run any blood gas, and depending on what the figures show, so if you're raised lactate, it's more likely to be ischemic. If they're acidotic, more likely to be ischemic, versus normal, then it's non-ischemic. If it's non-ischemic, we don't have a ticking time bomb that we're worried about. We do want to manage it, but we want to also rule out trauma causes. If it's an ischemic priapism, then we are very worried, and we want to be definitely having escalated to our registrar, having told the specific urology team that needs to be involved. And I would even have escalated this all the way up to the consultant if there is a priapism that's coming in. Okay, so management options. These are the management options, and I'll go through each one. So the first one, corporeal aspiration, which is very conveniently what we also need to get a blood gas. This is how we do a corporeal aspiration. So we discussed the anatomy previously. So just looking back at it, this is the penis. You've got the corpus cavernosum, one here, and the corpus spongiosum here. You've got the arteries inside there. So you stick a needle right into the corpus cavernosum and you would draw blood, and that will be your corporeal aspiration. So that basically draws out the blood that's been backed up and staying there and causing the erection the whole time. So the more you drain it out, hopefully you can reduce the patient's erection. And two, it helps you to make a diagnosis whether it's ischemic or non-ischemic. And it's very important when you send this blood gas off that it's the initial first few drops of blood that you get from the aspiration. Okay. Then the second thing to do, if the corporeal aspiration has not worked and the erection has not subsided, is we aspirate and wash out. So you basically aspirate a bit more, push some saline in, aspirate back out, push some saline in, aspirate back out, until the blood that's coming out is more diluted. So try and break up any clots that might have formed in the venous stasis that's happened. So that's the second thing you try. And unfortunately, if you fail that, then you try some intracavernosal injection of adrenaline. So I know that this might cause some end organ ischemia, but doing nothing also does cause end organ ischemia. So you do inject the adrenaline, but you only inject 5 mils at a time, really, really slowly. And you have this patient on a cardiac monitor to make sure that you're looking out for any signs of the adrenaline actually entering the systemic system. Now, if you think about it, this is an enclosed environment where the blood isn't flowing and is not in connection with our systemic circulation. If you inject adrenaline in here and you see no response in the patient, you're monitoring them and they're completely fine, they don't have a tachycardia, then actually what you're doing is not working because the system is still blocked. If you're injecting adrenaline and one, the erection is reducing, and two, the patient's heart rate is picking up, they're reacting to the adrenaline, then it means whatever you're giving is actually helping them and it's working. So you do need a cardiac monitor because you don't want to give them too much adrenaline as well. And unfortunately, if that failed, and the patient that I had the other day failed all of these measures, you need to do a surgical shunt. And a surgical shunt is not, not commonly done by all urological consultants, not something that everybody's familiar with. And you tend to need an andrology consultant who's someone that specifically deals with penile disorders, which is why this needs to be managed at a tertiary center, which is why the time is really important. So how you inject a surgical shunt is like this. So obviously in theatre with a penile block or under GA, so the penile block we went through earlier, under GA, we use a shunt directly into the corpus cavernosum, and we leave it open and allow the blood to drain out, and we allow it to actually to reduce the erection. Just on a side note, I found this picture quite helpful to understand the normal erection mechanism and the priapism. As you can see, you get normal arterial blood flow going in and venous outflow. And if you have a lot of inflow and the outflow is blocked, then you end up with the priapism. Okay, so the complications of priapism. The most worrying complication is that they might end up with erectile dysfunction, and 90% of these cases lasting more than 24 hours do not ever regain the ability to have intercourse. So they will require a penile prosthesis insertion if they would like to. And the prosthesis looks like that. So you've got a pump there. If they pump it up, then it causes the erection to happen. And obviously, like I said, this was what my patient needed fitting, but that's because they were transferred quite late. And in this case, if we go back to the history, this patient was at 6 hours, they were aware of the referral, and they only came to us at 10 hours. And even after 10 hours, we had to try all of these different methods. And where is it gone? Yeah, all of these different methods before we went to theatre. So basically the moral of the story, I guess, is if you suspect that someone has a priapism, then don't hesitate to contact your seniors very, very early. Okay. And now that we've gone through a little bit of the management, or all of the management of how to deal with this, you could get involved in steps 1 and 2, and even step 3 if you have a supportive senior around with you. Okay, so the last case that we're going to go through is your third night shift, and you've had an exhausting set of nights, all these emergencies coming in. But it's day 3 of your night shift, it's your last night shift, and it's 2 a.m. and you have a patient on the ward, Mr. Drew, who is a 79-year-old male, who is complaining of a fever and a lot of pain and worsening scrotal swelling. So just a little bit about his history. He actually came in earlier in the day. The on-call team admitted him and started him on some IV antibiotics, gave him some IV fluids, and are just observing his scrotal abscess. He's awaiting an ultrasound tomorrow. So, the handover was that he's not going to cause you much problems. Just keep an eye on him overnight. He's already on the right antibiotics anyway. So you go to see him and you ask for a set of observations, and this is what you get. So he's spiking a temperature. His heart rate is high, his respirate's rate's all right, and his oxygen saturations are okay. His BP is actually a bit low. And if you look at his past medical history, he has type 2 diabetes. Okay, he's got hypertension, but he has hypertension and his BP is only 107. So we're actually more worried about this BP than we normally would be. He has known alcohol excess and a previous TIA. So a lot of cardiovascular risk factors going on here. Okay. So what are we thinking about? He's got a scrotal abscess. We're thinking the scrotal abscess is getting worse. So you go and see him and you find that he's obviously clinically deteriorated. And when you try and examine him, you see a 8-centimeter scrotal abscess. It's very red, it's warm, it's tender. He's not really letting you examine it very well. But when you have a feel of the abscess, it makes a crackling sound, like there's something in there. And they've marked the scrotal abscess during the day, just so there is a comparison. And you can see that it's gone well over the mark. Okay, and you look at the perineum and you can see this necrotic, dead looking tissue. So we're very worried at this point. So what are we worried about? We're worried about Fournier's gangrene. So Fournier's gangrene, although rare, is a condition that I have seen once or twice during my shifts. So something definitely, that we do need to know about. So it's a life-threatening infection. It spreads rapidly and it involves the scrotum, the penis, and the perineum. It's 10 times more common in men aged 50 to 60. And if you can hear, gas within the tissues when you press on the tissues, palpable crepitus, we call it, is a very, very worrying and quite a late feature in the presentation, especially the necrotic tissue. If you're seeing any necrotic tissue, it's quite late. And, now he has obvious clinical deterioration. We've been sitting on this patient. I mean, we've given him some IV antibiotics, but apart from that, we've been sitting on this patient for, at least 10 hours during the day. So, and yeah, so necrotic tissue can be seen. So it's called gas gangrene when you have this palpable crepitus with the necrotic tissue, and it tends to be because of anaerobes such as Clostridium perfringens. Just so you know, it's very, very aggressive. It spreads very quickly. The skin just sloughs off and disintegrates on itself, and the mortality for these patients is 20 to 40%. And as you can imagine, having his risk factors makes it so much worse in this patient. So other risk factors for actually developing Fournier's gangrene is all of this, and really important to know about, because a lot of patients that we deal with have diabetes. Some of them are malnourished, some of them use steroids, and a lot of them have, these kind of risk factors. That is, when someone comes in initially, those risk factors help us to form a bit of a picture about, okay, this is something that potentially we would be worried about in someone presenting like this. And it should always be in the back of your mind when you're thinking about this. And especially if they've called you to say worsening scrotal swelling and ongoing pain and spike to temperature. So when I hear this, this is what I'm thinking as well. How do we investigate him? So obviously we send some bloods and cultures off in the time that we've seen this patient now, but we also request an urgent CT to confirm the soft tissue gas that we can hear and feel, and we call a senior. So I would say better to call them early, and they think we've called them too early than to call them too late in these cases, because it's quite a life-threatening condition. The mortality is very, very high. It has a scoring system, the LRI NEC scoring system. It uses these factors, but I think in the acute setting, we don't tend to refer to the scoring system. We act on the clinical picture and the patient. So how do we manage this? So this is a definite urological emergency. It tends to be in old patients that have some self-neglect, maybe in care homes, that aren't obviously, they're self-caring, so other people haven't examined them or haven't seen the extent of the swelling, of the gangrene possibly. So when they come in, they need aggressive initial resuscitation. So lots of IV fluids, obviously bearing in mind if they're going to be cardiac overloaded or etc. But aggressive initial resuscitation, we treat them with the sepsis 6 criteria. We give them broad spectrum antibiotics, and because it's most likely anaerobes, we should always cover them with an anaerobic antibiotic cover like metronidazole. And the only way to ensure that this patient lives is actually to surgically debride the necrotic tissue. If we have a very unwell patient that we've decided to manage conservatively with antibiotics, they almost always have 100% mortality rate with this disease. There is no non-operative management of Fournier's gangrene. Once you have the gangrene, source control is the only good management for them. So you need to debride and take away all the necrotic tissue, and you need to leave a good margin where the infection hasn't spread. And obviously send off any of this debrided tissue for histology and culture so that you know what to treat the infection with. Now, in this 79-year-old male, we want to think about sealing of care. It's quite important. We need to discuss with the family, with the patient, whether they would like all treatment, like active management. We need to look at his past medical history, his functional status, and we need to get ITU involved about possibly shifting to a higher intensity bed, so HDU or ITU bed. And I would say if we've decided to actively manage this patient, they should be placed in minimum a HDO environment, because these kind of patients will need several resections, like is said here. So you debride once and you come back out, but in the initial stage, you've taken out a chunk of tissue, but you don't have the time, or not the time, but you don't have the ability to reconstruct this area properly. Because if there is remnant infection and it's spreading again, you need to go in again and again and again and keep resecting. And by the end of it, when they're finally better, then you need to think about reconstructive efforts. But obviously, if you know that this patient is going to need it, discuss with plastics early. They will thank you for discussing them earlier rather than later, because plastics can be there with you in the debridement, and they can help you get good clear margins and also help you achieve the reconstruction that you're looking for. Okay, so that's the end of your shift. You've done 4 cases and 3 nights, and it's been a very, very difficult 3 nights. So you deserve your rest. I just have one more small case to go through with you, and it's not as common, but actually I saw it today at work. Penile fractures. So again, it's a rare emergency, and it tends to be young men that come in after sexual intercourse, and they have heard a sudden popping sound in the middle of intercourse. So it tends to be, blunt trauma. They get this popping sensation, lots of pain, swelling. They lose their erection immediately, and they can no longer have an erection. They have a traumatic rupture of the corpus cavernosus, or the spongy tissue that we talked about, and the tunica albuginea. Okay, so it tends to happen when we have violent deviation of the penis away from the axis. And if you speak to them, they'll give you quite a clear history of what exactly happened. They describe the sign that you get when you're actually examining the penis as an aubergine sign. And I actually saw it, earlier today. So they have a penile hematoma, firm, immobile, rolling sign. And we do this cavernosography. You don't need to know the details of it, but basically we try and do a scan to figure out. We could also do an MRI to figure out if they have this hematoma. Okay. And how we fix it. So if we think someone has a penile fracture, it's quite serious, because they won't be able to have any erectile dysfunction without fixing it, erectile function without fixing it. So you need to do a surgical exploration. You deglove the penis and you evacuate the hematoma, you repair the tear, and you can do this procedure up to a week after the fracture. But actually, everyone presents within the first half an hour of this happening, and we tend to operate on them within the first day or so of it happening. And the complications of it, obviously, if you don't treat it properly, is you can get penile curvature, penile paresthesia, and painful erections, and in some cases, erectile dysfunction. So again, another emergency just to be aware of. Just in the back of your mind, if you hear somebody referring to this kind of presentation, you are worried and you do want to see this patient. Yeah. Okay, so just some general tips. So this is the end of the presentation, no more cases, just some things that I wanted to let you know about. So I find quite helpful in emergencies to always follow a system of A to E, to rule out all the other key concerns before you get to E, which is normally when you examine someone's penis or scrotum. In urology, it's really, really important that you always offer a chaperone when you're examining patients, because all the time you're examining patients, and giving them the right privacy and chaperoning them during these delicate examinations are quite important. If someone has testicular torsion, a 4 to 6 hour window is very important. Time is crucial in a lot of the urological emergencies. Know how to put your catheters in. So this is quite a big topic, and I'm going to cover it later on in the second part of the urology talk. So that will be the urology common conditions, which is currently planned for the 20th of July at 7:30 p.m. So stay tuned for that talk. When you do catheterize patients, always replace the foreskin. Talk to seniors early. In urology, they are always happy to hear from you earlier rather than later, because like I said, a lot of things are time sensitive. And actually, urology is quite a fun rotation. There are lots of little procedures for us to get involved with, lots of opportunity, and even being in theatre, lots of small procedures that you're more likely to be able to learn and complete from start to finish on your own. And I would say that even as an F1, as an F2, and even medical students can come and get involved, and they're very, very happy to teach these small procedures to you. So that is the end of my talk. Thank you for your attention. These are just some of the references that I used. In general, I would say Teach Me Surgery online is quite a good resource for most urological emergencies and common conditions, and I found that quite helpful as well. Okay, I'm done. Any questions, anybody?
So we had one question on the group chat earlier on when we were talking about paraphimosis. Is there an option to make multiple small incisions when performing treatment to try and relieve the pressure?
Yes, definitely. So in the Dundee technique, you actually do multiple small incisions. You do up to 20, sometimes even up to 50, which is why it's really important to give them a good block before you start doing them.
One more question. Any penile block before aspiration? This is from part 2 of the lecture.
Yes, definitely. So I would always do a penile block before you do anything, because it might be a long process of reducing this person, and you don't want to start that process off by putting them in more pain. They're less likely to let you do more of the procedures afterwards. So before you do anything, I would start with a block.
That's all. Thank you all very, very much.
Thank you.
Tomorrow we have our pediatric surgery session, and that's going to be at 6:30 p.m. So don't hesitate to join. The link will be in the Instagram page link section. Thank you.